Hello and welcome to RUMC Vital Signs. I'm Alex Lutz. On our show, you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit rumcsi.org. Excluding skin cancers, colorectal cancer is the third most common cancer diagnosed in both men and women in the United States. This is according to the American Cancer Society. ACS also estimates that over 107,000 new cases of colon cancer and nearly 47,000 new cases of rectal cancer will be diagnosed this year alone. The good news is the rate of people being diagnosed with colon or rectal cancer has dropped significantly each year since the mid-1980s, but it still remains a serious health concern, especially here on Staten Island. Here to further discuss this form of cancer is board-certified gastroenterologist Vahe Shahnazarian. In addition to Dr. Shahnazarian's credentials, which you see on the screen, he's been published in numerous times in world-renowned medical journals and is often requested as a speaker at national conferences around the country. Dr. Shahnazarian currently sees patients at one of two locations on Staten Island, where he has offices as a member of Richmond University Medical Center's Richmond Health Network. Welcome to the show.
Thank you for having me.
Thanks for coming on. Could you just take a few minutes to kind of help us understand what a healthy colon and healthy rectum do?
Yes, so essentially the major functions for the colon and rectum are to help you finish absorbing nutrients that you've ingested, to help you take some of that liquid out of the food that you ate and to start bulking up your stool. And as that stool starts to form and goes all the way down into your rectum, then you get that sense of having to have a bowel movement. And so that's major functions, and as long as things are working properly, most people have a regular bowel movement and are able to kind of tolerate what they're eating and stay on a schedule in terms of having their bowel movements.
And it's often referred to as colorectal cancer, but there are actually two different kinds of cancers?
Yes, so colon cancer is a separate entity, rectal cancer is a separate entity. In terms of screening, the screening is the same recommendation-wise, but depending on which one someone is diagnosed with, their follow-ups, their treatments, those things may differ.
So how does colon cancer start and how does it spread?
So colon cancer will always start as a polyp, as a colon polyp. Once that tissue receives that notification incorrectly to start proliferating, it's going to start growing and growing and growing. And once it grows enough, it becomes a colon polyp. And there's benign polyps, there's precancerous polyps, and those polyps can eventually quickly turn into colon cancer. And once it's taken that extra step, which is called dysplasia, to go from a regular colon polyp into now what we consider something that's more highly likely to become a colon cancer, then it eventually will grow into a colon cancer. Some, again, much more quickly than others. Once it's grown enough, then it'll start to break down the tissue barriers in the colon and get into your lymphatic system. So that's when you hear like a lymph node will be positive, for instance, and that's when you know it's already started to spread.
I see.
It might end up in the liver, usually that's where it goes first, and then it could end up anywhere else in the body.
Why the liver? Is there what's the connection?
It's the way that the drainage happens from the lymphatic ducts at that point and the vasculature. The liver is the first stop, essentially, of the major organs.
And a polyp is like a nodule or something that?
Yes, it's essentially an overgrowth of normal tissue. And then eventually it either it already has the mutation in it, or it catches a little mutation and it starts to change into now precancerous tissue.
And is colorectal cancer an aggressive form of cancer? Is it slow growing?
It can be. So some of them are very aggressive, some of them are slow growing, so that's why regular screening intervals are very important.
And what are some of the risk factors and the symptoms of colorectal cancer? So
some risk factors, some that we can control at least, include smoking. So not smoking helps a lot of patients avoid getting colon cancer. Eating red meat gives you a risk for having colon cancer. Eating processed foods like deli-type meats, bacon, things like that will increase your risk. Some risk factors that we can't control, having inflammatory bowel disease like ulcerative colitis or Crohn's disease. having a family history of colon cancer, and having certain genetic syndromes that can really predispose you to developing colon cancer amongst other cancers as well.
Right. And so those are risk factors you obviously can't control.
Yes.
What is it about processed meats and red meat that it seems to be?
It just has to do with how they're digested, and they kind of cause a little bit more quote-unquote damage to the tissue where it tries to repair it, and the more repair that you have throughout the body, the higher the chance of eventually one of those repairs will go haywire, and you get that little mutation.
I see. And is colorectal cancer like other cancers where the first symptoms usually no symptoms?
Correct. Actually, there are absolutely no symptoms for polyps or early colon cancers. By the time you have any symptoms at all, unfortunately, it's usually a later stage, which again is why it's so important to have these screenings before you're symptomatic.
And what are some of those symptoms?
So some of those symptoms can include rectal bleeding. It can include unintentional weight loss. They can include changes in the shape and size of a person's stool, especially stool becoming kind of thinner and staying that way. Usually that means there's some sort of a mass constricting the colon at that point. Those are really the major signs and symptoms. Some more vague symptoms can be like abdominal pain, and really that's pretty much it, honestly, in terms of like the major things to look out for.
And if someone is experiencing this, comes to you, how do you diagnose colon cancer?
So diagnosis is typically by colonoscopy. Imaging, things like that can kind of guide us a little bit, but colonoscopy, direct visualization, and biopsy, so tissue sampling, is the gold standard for diagnosis.
And the colon, correct me if I'm wrong, is almost like an inverted U underneath.
Yes.
Okay. Is there a section of the colon where cancer tends to be more prevalent, or it can be anywhere in the colon?
It could be anywhere in the colon. The right side of the colon, so on the right side of your body, that typically tends to have more aggressive cancers, and they're flatter polyps usually, which are more difficult to detect, and those typically, for whatever reason, based on the pathology of the tissue, tend to grow faster and more aggressively.
Okay. And if someone is diagnosed with colon cancer, what are the treatment options?
So most colon cancers will require some form of surgery. Usually the only time surgery is not an option is if a patient is very sick or they just won't tolerate surgery in general due to their health. But also in case they don't want chemotherapy or radiation or something like that, and they want to do more comfort measures. Otherwise, surgery is pretty much always indicated. And then depending on how early it's caught, surgery could be curative, which again goes towards doing your screening at the appropriate times. But some patients do require chemotherapy and radiation as well, and those are some other options that we do have.
And surgery is to remove the section of the colon, or just the cancerous growth?
Yes, so what we can do during the procedure, if we find a colon cancer or something that looks like it should come out surgically, you can actually tattoo it from the inside of the colon. And then when the surgeon places their cameras, either robotically or laparoscopically, they can see the outside of the colon and they see the borders. So we give generous borders so that they can remove that section, and then as long as their tissue is healthy enough, they can reconnect in that same procedure and not have like a colostomy bag or something like that.
And what are the survival rates for colorectal cancer?
It all depends on the stage that it's diagnosed at. Early colon cancer, survival rate could be 100% because it's fully curative surgically. Later stages, unfortunately, that percentage will drop.
You know, a lot of people, when they hear that diagnosis of cancer, they immediately think it's a death sentence. But as we interview more and more oncologists and doctors, we're finding out with treatments in modern medicine, it's not the case. And are you seeing that also with colorectal cancer?
Yes, absolutely. And 5-year survival rates, percentage-wise, have definitely gone up. Quality of life has gone up with the survivor percentage rates as well. So the advances that are being made are great. There's much more targeted chemotherapies now, and it's really making a difference.
And what are the recommendations for screening for colorectal cancer? When should you start? What should you do?
So it used to be to start at age 50. A few years ago, that recommendation was changed to start at the age of 45 because we were finding colon cancers in a lot younger people, which we aren't sure why yet. So it is 45, typically every 5 to 10 years. guidelines will state about every 10, but depending on what you find, the size of the polyps make a difference, the number of polyps will make a difference. So all of those things will kind of guide us as to when the next colonoscopy should be. Family history will make a big difference. Genetic history for the patient themselves will make a difference. So it's all kind of tailored to the patient, but the general recommendation is to start at the age of 45. And then if you have any of those other higher risk factors, definitely speak to your primary care or gastroenterologist for your specific recommendations.
We said at the top of the show that the diagnoses of colon cancer are dropping year after year. Do you attribute that to people just being more aware of it, better screening, or better identification of colon cancer?
I think it has probably to do with better screening and more awareness.
Right.
Primary cares are doing a fantastic job reminding patients, constantly reminding some patients that you're overdue, you're overdue, you're overdue, or it's time to go. And then we also have tests for patients who just don't want a colonoscopy, for instance. Well, it's absolutely the best test to do. Some patients just don't want it, which is understandable, as long as they understand the risks of not doing it and what the other tests may or may not miss, the stool test. But doing the stool test is better than nothing. So we recommend doing at least something. And then if a stool test becomes positive, we'll really sit down and have the discussion on why the colonoscopy is so important at that point.
And we talked about age, we talked about family history. Do you find that there's a certain demographic of the population that is more prevalent to colorectal cancer?
It is more prevalent and higher risk in our African American patients. That's typically been the case, and in fact, before everyone was recommended at 45, it used to be African American patients were recommended at age 45 even prior to this. So now, but everyone is recommended to start at 45.
Right. I remember a couple of years ago, the actor Chadwick Boseman passed away at a very young age from colorectal cancer, and I think that sparked, I remember it sparking, especially at RUMC, a lot of awareness. A lot more younger people were going to their primary care doctors after he passed. So if there's a silver lining to his passing, hopefully it means that people went more for it. You mentioned colonoscopies as being kind of the gold standard. Just briefly, what is a colonoscopy?
So colonoscopy is essentially a camera at the end of a tube, and we check the entire large bowel, the colon, and there's a light at the end of the tube as well, and now the technology is way more advanced than it was even like a decade ago. And it's ultra bright white light, and it really helps us see everything inside the colon. You have some air or carbon dioxide placed in the colon as well through the camera, and that helps the colon expand so that you can really see all the surfaces of the tissue as you're very slowly coming out of the colon. And then the patients are fully sedated for this, so it's a very comfortable procedure. You're sedated as if you're sleeping at home breathing on your own. So there's no tube down your throat. It's not the gas anesthesia that a lot of people say gives them nausea or headaches or something like that. In fact, most people wake up from this type of IV sedation feeling fantastic. And so it lasts about 15-20 minutes on average, can take a little bit less time or longer depending on what I encounter during the procedure, if there's anything I need to do outside of just looking. So if we do encounter polyps, this is the beauty of colonoscopy. It's really the only test in medicine that offers this. It's screening and diagnostic, kind of everything wrapped into one. It's a therapeutic. If you see something, you can immediately remove it at that time, as long as it's a lesion that looks like it will be safe to remove during that procedure.
And this is more like it's an outpatient procedure, right?
Correct.
Yes, and you can do this in the office. You don't have to be in a hospital setting.
Yes. So depending on every patient's health status, if they're healthy enough to do it in the office, we offer it in the office at the Richmond Avenue office, and that's with an anesthesiologist, full monitoring, full recovery area. But if a patient does have certain medical conditions that we feel like they would be safer to do in the hospital, then we'll do it on an outpatient basis in the hospital. So they'll still only be there for like 1 or 2 hours. They come in, they register, we'll do the procedure, we give them ample time to recover, and then they get a ride home from a friend or family member.
So actually, I was going to say, you kind of walk, if I was someone coming in for a colonoscopy, kind of walk me through that process? What am I doing? What are you doing for me?
Yeah, so it starts with an office visit. We get to meet, we'll talk, we'll see how you're doing. I'll give you your options, I'll explain the preparation to you, I'll explain the risks and benefits of the procedure, because I want that full, I want you to understand what's going to happen, and I want you to buy into what we're doing together, essentially. So then at that point, we'll pick a day and time and a location for the procedure. The day prior will be your preparation day, where you drink the liquid or take the pills and essentially go to the restroom a whole bunch to clean out your colon for us, okay? So that we could see everything inside really well. And then after midnight, you wouldn't be eating or drinking anything. We would tell you which medications not to take for the procedure day or leading up to the procedure. You come into the office or the hospital. We talk again. We'll take your consent. We'll do the whole intake procedure. You'll get a little IV from the anesthesiologist. You're going to be comfortably asleep. Again, you won't feel or remember any of the procedure. And we'll take a good look. You wake up. We'll talk about what I saw, what I did, how we should follow up on anything, if at all. And then once you feel like you're back to normal, awakeness-wise, I guess, you get to go home with a friend or family member, because you can't work or drive that day, just due to the sedation.
Okay. And are there's no side effects, long-term side effects to an actual colonoscopy? No
side effects whatsoever. In terms of how you might feel that day, it is possible to feel a little bit bloated or gassy or a little bit of cramping for an hour or two after the procedure, because you are full of that air that was placed in there to expand the colon a little bit. Most patients fully pass the air before they even leave the office or the hospital, but some people do feel a little bit uncomfortable for about an hour or two. But in terms of complications in that sense, no like long-term issues or anything like that.
And if the starting age is 45 for your first colonoscopy, how often should you have one done after that?
So it depends. We recommend every 5 to 10 years at minimum. The guidelines will say you can go up to 10 years, but we do sometimes find these interval lesions or polyps that kind of happen on the tail end of that 10-year period, and I have a feeling probably within the next 5 to 10 years, they're actually going to cut down on that number, just because of the numbers of colon cancers that we do see. But it's all going to depend on what was found during your procedure specifically. And
do you go more? Would you recommend someone going more frequently if they have some of these risk factors, like you said, family history?
Yes, absolutely. Some people with family history will max them out at 5 years, depending on who had the colon cancer in the family, at what age they had the colon cancer. Some people with their own history of colon cancer, depending on when the surgery was done, it'll be in a year, 3 years, then every 5 or so. If someone has Crohn's disease or ulcerative colitis and that was diagnosed over 8 years ago, they should technically be on a yearly schedule at that point, because their risk of colon cancer, even if their inflammatory bowel disease is well controlled, can be significantly higher than the standard population. So everyone's kind of unique.
You talked about how you're seeing or diagnosing younger and younger, and there really isn't a cause for. Do you, not to put you on the spot, do you have an idea of why you think that might be happening?
The general thought process at the conferences, at least, is that it's probably related to diet and environment. Our diets have significantly changed over the decades. Yeah, and we're exposed to a lot more carcinogens nowadays, just even walking around. So it seems like that's what it's more related to, but there's no solid answer yet.
And are you seeing any trends here on Staten Island?
I mean, Staten Island has the highest rate of colon cancer in the 5 boroughs. So that's something, I have not worked outside of Staten Island for a few years now, but I was in Brooklyn, Queens, and the Bronx at a certain point in my training. It does feel like we tend to diagnose it a little bit more here, but that's just subjective.
Right.
Yeah, but actually numbers-wise, statistically, that is true. Just subjectively in my practice, that's how it feels as well.
And that seems to be a common trend among other oncologists that we've had, from breast cancer to at Staten Island. It's not the time you want to win the race.
Right,
it's not an area you want to win the race. But at least we know where there seems to be a lot of ways to diagnose and to screen. So we've heard about Cologuard, we've heard about FIT kits. What exactly are they? How do they detect colon cancer?
So they both use stool, essentially a stool sample, to detect, at the very least, microscopic blood in the stool.
So these are actually blood tests?
Technically, yes.
Okay.
So the Cologuard is the most advanced one by far. You know, it checks the stool sample for microscopic blood, which you wouldn't visually see. You know, your stool would look brown or whatever color and not have any red in it, for instance, or any black, which is also another indicator of blood in the stool. But Cologuard also checks for large polyp DNA and colon cancer DNA in the stool as well. So it's the best stool test to do, like out of the stool tests. And FIT testing is quite good as well. It's more advanced than the very old testing of like the stool cards, where you'd have to smear stool sample on the card and put the developer on it and everything. That's kind of very outdated at this point. So FIT testing kind of took over that. But then the best non-colonoscopy test to do right now is the Cologuard test.
And they're pretty accurate?
They're in the low 90s, so it's better than nothing.
Right.
It's not as good as colonoscopy, but it's definitely the best stool test to do.
So it's something that you should do, but not to replace a colonoscopy if you get that recommendation.
Correct. And also, if you've ever had polyps on a colonoscopy, you should not be doing stool testing after that. If you have any family history or personal history of colon cancer, you should not be doing stool testing.
Okay. So it'll just be colonoscopy directly. Okay. So now we get to a little conversation on the wonderful prep. That seems to be the one thing that most people avoid. How has the prep changed over time, and has it changed for the better? Because it seems to be the barrier that people are like, that's why I'm not doing it.
Yeah, so we started with the big gallon.
Yes.
You know, that's still around because unfortunately that's the most covered one by insurances. But that being said, preparations have evolved greatly. Now a lot of them are split dose, so you're doing a little bit and then a little bit like 4 or 5 hours later. You could even split it, one in the morning if you wanted, like one at night prior, one the next morning. So nowadays it's almost more drinking anywhere from 5 to 16 ounces per prep. Now that's just the preparation part.
Right.
You're still going to be drinking a lot of liquids, but just clear liquids. Broth, Gatorade, apple juice, ginger ale, whatever you like at that point. The preps don't taste great. That's the truth. But there are ways to help take them. You know, you could take a big gulp, you hold your breath, you drink some ginger ale right afterwards, you barely even taste it. There are pill preps now as well, one in specific. It is 24 pills, so it's not a small amount. Yeah. And it's 12 pills and 12 pills, you know, 4 or 5 hours later. But it does work quite well. Again, you're drinking a ton of liquids with it, so if your aversion is to just liquids, we still have to kind of figure something out for you. But I get pretty good feedback on that. It's not always covered by insurance, so that's kind of the downside. But we do work with some pharmacies that could get it for as little as $40, $50 sometimes, even if it's not covered at all. So some patients do still opt for that.
So when you have someone that you encounter that is resistant to, how do you, I mean, obviously it's better to, I mean, it's one day of discomfort for what could be, but when you do encounter someone that's hesitant to it, how do you explain to them, hey, this is really in your best interests?
I first try to find out why they're hesitant. You know, some people are worried about the procedure. Some people are worried about risks. Some people don't want to do the prep. Some people think it's going to hurt. You know, there's a lot of possible reasons. So I just do my best to kind of sit with everyone, discuss it in detail, and try to tease out what's bothering them about it, and if it's something we can kind of guide you through and make you feel okay about. Because there are small risks. It's a very low risk, minimally invasive procedure, but like everything else, you know, you go get your blood drawn, that's got its own risks. So those risks are all manageable. And a lot of people like to kind of hear what they are, how well, you know, you're able to do these procedures, how many you've done. Some people are just nervous, you know, and which is totally normal and acceptable.
How many would you say you've done in your career?
Thousands at this point, yeah.
That's a good high number. It's a good high number.
We did about 2,000 before I graduated, so since then it's at least quadrupled at this point.
And as someone who's had colonoscopies himself because of family history, it actually, I remember when I first got my first, the prep has changed for the better, or as I feel it's better, or maybe my body's just tolerating it a little bit better, but it has changed. And I think that's a big misconception too, and it keeps people away. And then when you finally go through it the first time, it's not so bad. And I'd rather have a day of discomfort and find the truth and know that I'm okay than sit there and not know what's actually going on inside my body.
Right, exactly. And a lot of people are worried about the fasting. I'm going to be really hungry. You can drink so many liquids if you want that you will absolutely not be hungry. And then that prep is really, nowadays, the prep starts around 4 o'clock and you're done with both parts of it and in bed by like 10. So it's really not as bad as it used to be.
Oh, that's good. So in our final moments, I guess, one of the questions I wanted to ask you is, you've been a gastroenterologist for how long now?
Almost 6 years.
How has, even in that 6-year amount of time, how has your field changed in its attack on colon cancer? What are some of the advances that have been made, and what's on the horizon that looks promising?
Well, just in terms of colonoscopy, the technology's gotten a lot better. Mm-hmm. Between improved lighting during the colonoscopies inside, improved devices that we can use to remove polyps and certain growths that are even a little bit past polyp phase but not cancer yet, so that we could spare someone a surgery and chemotherapy and everything. There's artificial intelligence now that helps detect polyps as well during colonoscopy.
AI's everywhere.
Yes, and right now it's not that great, but I think in the next 5, 6 years it'll probably get a lot more useful. And then in terms of actual treatments, surgically, robotic surgeries are minimally invasive. Recovery times are drastically cut. If you do end up needing surgery for like a very large polyp or a colon cancer, there's a lot of targeted immunotherapies now. People are tolerating the chemo better because the chemo is more targeted now, and the cycles are changing. So all of those things are kind of helping us deal with the colon cancer portion of it a lot better as well. But the main goal is to not get colon cancer. And so get your colonoscopy, get your Cologuard, whatever it takes, get them done at the right times. What's the saying, like, every colon cancer starts as a colon polyp, which is, it's the most preventable cancer that we have, and because of these great tests that we have. So it's a real shame when I hear people ignoring their screening recommendations or ignoring their own symptoms. Everybody knows their body the best. So listen to your body. When it tells you something is wrong, go see your doctor.
It's a great point to end on. Thank you for coming on the show. I really appreciate it.
Thank you very much. This was great.
Thank you. If you'd like to schedule an appointment with Dr. Shahnazarian or have questions about colorectal cancer, please call either of his offices at 718-818-2066 or 718-984-9658. Dr. Shahnazarian has offices at 2066 Richmond Avenue or 4434 Amboy Road. To order a free at-home test kit for colorectal cancer, you can call our Oncology Services Department at 718-818-1141. Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for over 120 years. You can help ensure that care continues by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the Donate button located at the top of the homepage, or you can call 718-818-2106. That just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.